Welcome, everybody, to the Help for Hip Dysplasia podcast. I have the absolute privilege this week of introducing you to Dr. Charles T. Price. Now, Dr. Charles Price is the director of the International Hip Dysplasia Institute and has been an absolute legend in the hip dysplasia world. So I'm very, very proud to introduce Dr. Charles Price. Hello.
Thank you, Laura. This is great, and what you're doing is so important. It's a pleasure to be here, and I'm looking forward to our conversation.
Me too. I also want to introduce to everybody Natalie Caro, and Natalie has been absolutely incredible about helping us to coordinate this conversation, but is also the program director for the International Hip Dysplasia Institute. So, hi, Natalie, I want to say hello from everybody and thank you also for the work that you do. Okay, so I'm so excited to be able to bring you so many questions from the community this week. I put out a post on social media asking for questions, and we were absolutely inundated with questions coming in from everywhere around the world. So thank you so much for taking the time to answer those for us today. I wonder if you might be able to just give us a little bit of background in your history with hip dysplasia and what's brought you to this moment being the director for the International Hip Dysplasia Institute.
Well, that's a longer story that we probably have time for, but it's been a pleasant story, and I think uh, that I've had a long history as a academic or children's orthopedic surgeon with an interest in hip dysplasia, and had a patient from a well-known comedian in the United States, Larry the Cable Guy, and his child was sent to me for treatment, and we had a very successful result. And his wife said she wanted to do something to make a difference because she first time she heard about it, it was about dogs. She didn't know that people got hip dysplasia, and there wasn't a website, and there wasn't a lot of. It was just a mess, really. She'd been told one thing by different doctors, and I'm sure that still goes on. That there's a lot of confusion and questioning, and so they wanted to make a difference. And I told them, I said, look, I said, this is a little bit of research money is going to help, but it's not going to make a big difference because there's no implant company working on this. There's no pharmaceuticals for it. It's not life threatening, so it doesn't get a lot of attention from grants. And so it's going to take a really colossal donation to really do a deep dive into hip dysplasia and make a difference. And they stepped up and made a $5 million donation and said they wanted to make a difference, which was it was a lot of money, even for them and for us. Well, then that really was intimidating to me, actually, because I thought, wow, now I've really got to get to work. And she said, you're an academician, you've published research, you can do this. And she gave me a lot of encouragement. Kara Whitney's her name. And really, it's amazing, not just the money they gave us, but the support and encouragement. And she was right on target. She gave us a list of things that she wanted to do. And at the time I looked at the website, did some analytics. There were a couple of websites that were getting 100 or so visits a day. And we're over 1 million visitors a year now. And then, with that money, we did institute a lot of research programs. We standardized the first thing we did was standardize the classification of hip dysplasia so we could compare apples and oranges, and that's become a national standard now. As an international standard is the International Hip Dysplasia Institute classification system, and we've had about 30 scientific papers from all of our work as a collaborative team. We put together a team of experts from around the world and kind of outlined a plan of tackling hip dysplasia rather than seek grants. We said, here are the steps we need to do. We need to do step 1, step 2, step 3. We need to standardize some things. And so we had a targeted approach to use their money. And in addition to our work, what's happened is that has generated a lot of enthusiasm in the community, and people like you are providing information that's so needed. There are many organizations now, and we welcome them all. We think the websites and podcasts and things that are spreading information are so vital to this project, that the word about hip dysplasia is getting out. And there's a massive amount of new research and new interest that kind of has really been kindled through this gift. So I was just fortunate to be the instrument in all of this.
So you mentioned that obviously it's creating a little bit more awareness in the community. Lots more people are wanting to get involved in different forms of media and different forms of raising awareness, different information that's being created. Um, we're obviously coming up to Hip Dysplasia Awareness Month that is being coordinated with Miles for Hips as well. And my good friend Nancy over there has been wonderful in trying to coordinate all these different things to raise awareness. But I've also had questions coming in from people to ask how they can get involved and how they can make a difference. Um, obviously there's fundraising and things happening, but what can people be doing to help create awareness with hip dysplasia, or are there any other volunteering things that people can do?
There are a lot of things people can do, and I think Laura, you and Nancy are good examples of people that just took the plunge, and we just can't have too many voices out there doing what you're doing, because there are a lot of people in need, and that's been the most overwhelming thing to me is how many people have this condition. It's the most common cause of hip arthritis. It's a reason for 10% of all total hip replacements, and there wasn't really a collective awareness. People thought they were alone, but there's a massive number of people that have this. And so first I would challenge people to do the things that you and Nancy have done, with come up with your own ways to be involved and do things. And that's difficult. But we've got a website we've got a page on our website, which is Get Involved. And it has some suggestions, including being involved with Miles for Hips. And they can volunteer for that. They can just talk about it in their neighborhood. I would say some things that they can do is, in addition to looking on our website and see how they can contribute, they can write their story, put their story on our website. People read those things, they touch hearts, and they help people get through difficult times. So whether your story is a positive story of success or one where you've been through a lot of trouble, it's really beneficial to post that story on our website. Then um, we're thinking about having some activities like a thank you squad, who would people who are grateful that could write thank you letters to some of the donors that have gotten involved. So we're looking at ways to expand people to be involved. Another thing is to talk to your doctor. If you have a young child or a newborn child, look and make sure the nurses in the nursery know how to swaddle properly, and ask your doctor if your hospital is using good hip healthy swaddling practices. And so mainly just being aware and an advocate and an educator. Follow us on Facebook, become aware, and talk about it, because we don't want a mom to have her, or anyone to have their first thing, the doctor says you have hip dysplasia, and they go like, what is that? Yeah, we want them to at least have heard the term before it happens. Everybody knows what psoriasis is, but not everybody knows what hip dysplasia is.
No, absolutely. Um, so one of the things that was definitely something that I've recognized as a really common theme from, all of the people that I've had the privilege to speak to, is the sense of community and support that people are now being able to get from these different mediums. And I think one of the biggest problems, like you mentioned, people don't know what it is. People hear this term for the first time, they don't know what it is, and they just feel completely alone. So yeah, by sharing your stories, being able to put them up on your website, whichever way you can share any information, is going to help more people feel less alone. And
Yes.
it's just such a wonderful thing to be able to do. So every time you speak about it, you're helping somebody else to feel less alone. So yeah, thank you for that. It was an absolutely fantastic point to cycle back around to. So there is so much research that you've done in the hip dysplasia world and been involved in. And obviously we won't have a chance to speak about all of it today, but I did want to kind of ask about whether there's anything in the pipeline or going on behind the scenes to start thinking about how we can get more people diagnosed at birth, because this is such a massive issue around the world in terms of the statistics of people that are missed, the assessment methods that we've used for a very, very long time, and how cost is implicated in so many different countries as a reason for these diagnoses being missed. So I wondered whether you might feel happy to talk about that a little bit and whether there are any kind of progressions coming.
Well, that's the that's really the what we're chasing now. And I would say just briefly that we started a registry which now is operated by Kishore Mulpuri in Vancouver, called the International Hip Dysplasia Registry, which doctors from all over the world are entering their information. And that's kind of looking at what our current standards are, what our current practices are, and try to refine and improve the outcomes of diagnosis and treatment that we are using today. And that's very necessary. But what the International Hip Dysplasia Institute, our research goals are what we would call paradigm changing research. So we are really trying to use our money wisely to invest in research that's going to really revolutionize the nature of things. And one of those is to improve diagnosis. One of our studies showed clearly that the clinical examination, even when performed by experts, is inadequate. That's been known. And even Ortolani, when his book was translated from Italian to English, which we had done, in his book, he says this won't diagnose the most severe cases. And so we've been using a flawed examination technique for years and years. And so if it's missed, it's not really the doctor's fault. And ultrasound, even in countries with nationalized healthcare systems, is not always employed because it's expensive, has to be done at 6 weeks of age, it requires a return treatment, it requires a lot of technology and experience. And so we thought ultrasound was going to solve the problem. And countries that employ universal ultrasound have decreased the miss rate, but it's just not technically possible. So the things that are coming in the pipeline, we are conducting some fairly advanced research on listening to infant hips, believe it or not, just with a stethoscope and a tuning fork. If you put a tuning fork on a baby's knee and listen with a stethoscope, the sound of a stable hip is different from the sound of a dislocated hip.
This is exciting.
Yeah. And so we're really pursuing that. It sounds like you should be able to do that immediately. And it's pretty accurate for detecting dislocation on one side because you can compare one side to the other. But when you have both hips or mild displacements, it's not as good. But when you look at the technology of listening for warfare and things like that, I spoke with one group of acoustical engineers. They said, oh yeah, if you move a dislocated hip around, it'll make a different sound than a hip that's reduced. And so it's a matter of quantifying that and making it translatable. So what we're trying to do is develop a little battery operated tuning fork and a stethoscope that could be carried anywhere in the world for, under $200. And you could listen to babies multiple times during their baby. So actual, because sound, vibration is transmitted sound and ultrasound is reflected sound. And so there's a difference in the reflected sound, like sonar would be used in the military, and the difference between sonar and transmitted sound reflect. So one thing we're trying to do is to try to find ways to listen to baby hips better. And we think that with modern technology, anything's possible. And so we think we're going to get there, but we're spending our research dollars on that. Another thing is that with facial recognition software, there are several places around that are looking at handheld ultrasound wands that you could put on a baby's hip and automatically recognize whether the hip is reduced or not. So with facial recognition, like you can take pictures of somebody's face and then it can say, you can take a side view or a front view and it'll say, well, this is Laura, and we want to do that with hips too, so that you put the wand on and there actually are wands now that are powered by a personal digital assistant. So it can go into an iPhone and you can do bedside ultrasound. The trick is right now, it still requires some technical expertise to get the hip ultrasound properly. That would be more expensive, but more doable. And I think we're going to see that in the next 5 years, that there'll be an ultrasound wand that you just kind of put on the baby's hip and it'll show a picture that's either stable or not stable. And that could be easily done in the pediatrician's office or somebody else's office. So I think technology is going to be the answer for diagnosis, and making it inexpensive and widely available is what we're after.
Absolutely. And to be able to be done by a wider variety of people and technicians rather than having to be a certain um,
Yeah,
level of qualification, I suppose, to be able to understand the readings
exactly.
on it. So
Battery operated and portable. So until then, I think we're still going to have late diagnosis, and it's heartbreaking, but it's time to stop that. Yeah.
but the fact that we even have these things in the pipeline and things that are being worked on towards this goal is hopefully, I mean, it feels like a massive weight off my shoulders just knowing that something's being done, but I hope that that brings relief to many people, knowing that, you know, the awareness that people are raising, the donations and the fundraising for this research is going to make a real massive difference to not only something small, but this is really fundamentally tackling the cause of so many people's issues, because a lot of the people that I have the privilege to speak to are people that are struggling in adulthood as a consequence of these misdiagnoses and having to go through quite
Right.
traumatic surgeries. Um, but if we can have all of the diagnoses being made at birth or, you know, in the first few months of life, then the amount of people that are later on in life going to be struggling is just going to be significantly reduced. So what I love about what you're doing over at the International Hip Dysplasia Institute is really tackling the cause of the problem.
Right.
And we're not, you know, obviously there's going to be stuff being done, you know, around the other stuff that can't be changed at the moment. But I
Yeah.
love that we're addressing the cause of the problem and hopefully changing this for the generations in front of us so that they don't have to struggle with some of the things that some of us are currently struggling with. So it's inspirational to hear about. And thank you so much for the work that you're
Thank you.
doing.
Well, we're actually working in three main areas. One is prevention, because we don't want adolescents to find out they've got dysplasia later either. So that stable type of dysplasia, which is mild dysplasia in infancy, um, with there may be some ways of proper positioning infant practices that if we can show biomechanically and some other ways, that we're working with some biomechanical engineers and some modeling programs to show that we don't know yet whether early positioning treatment really makes a difference down the road. But in Austria, for the last 30 years, they've used positioning devices, and I would say prophylactically managing a whole lot of infants, maybe 1 in 20, when they find mild dysplasia on their universal screening. And they have decreased the arthritis level in the young adult population and decreased the number of PAOs being performed. So there is a suggestion that early infant practices may make a difference in the adolescent and adult population. So we're looking at possible prevention methods. We're looking at early diagnosis. Then we want to get rid of casts and surgery for the kids that are diagnosed late. So some of our biomechanical research is now generating some material that would show how harnesses could be more effective. The
Mhm.
pelvic harness was a great advance, but it only works 85% of the time. Well, we want it to work 99% of the time, and we want it to work up to age 18 months so that
Oh,
kids don't have to go in casts. Now, after 18 months, there's enough deformity that they have to have surgery. But if we can manage kids up to 18 months as an outpatient with harnesses and braces that are more effective, then we wouldn't need casts and anesthesia and early surgery. So we're really working on three fronts to do some things that aren't even conceivable right now with what our technology is.
but it definitely gives us a bright outlook for the future. So this brings me really nicely actually to my next question. So there is a question that came in that says, what is the likelihood that children that are treated at birth having had hip issues as adults?
Well, that's certainly one thing we're finding is that even the successfully treated infants, about 10% of them show up with dysplasia as a young adult. So we don't know whether our successful treatment stopped too soon or whether it's a recurrence. Um, it's possible that the adolescent type of dysplasia, the ones that need the PAO and all that type, it's possible that that occurs during adolescence, just like teeth can get crooked or nearsightedness occurs or scoliosis develops. There are a lot of growth disorders that occur in adolescence where things don't quite finish out right. And we're working with a fantastic group of researchers at the University of North Carolina that we hope to have that answer. Because if it's something that can be prevented from birth by more nighttime bracing or more effective bracing or just another 6 weeks of treatment, then that would be easy. If it's something that occurs in the 12 and 13-year-old age group, then we need to look for other ways to prevent that. My own opinion is it's probably a little of both, because we know that 10% of the successfully treated pelvic harness kids will get arthritis and recurrent dysplasia as an adult, but there's probably a subgroup that occurs during late adolescence. So it's probably a little of both.
Okay. So this question is really relevant to that one. So this one comes in actually from my sister, who had dysplasia as well as me, and was treated at birth. Thankfully, hers was found really early, and she had the harnesses as a baby and doesn't have any issues in adulthood at the moment. But she says, if I had the harness as a baby, what should I be doing as an adult to make sure I'm hip healthy?
Well, does she know whether she has dysplasia residual or not?
Never been followed up.
Okay, well, I think, that's really a question right now. Somebody who was treated as an infant, should they have an x-ray when they're an adult? And the general feeling is that probably after age 10, it doesn't hurt. If you've never had an x-ray after age 10, it doesn't hurt to seek an opinion and have an x-ray. X-rays have very low radiation nowadays. Digital imaging is almost non-existent, I mean, for radiation. And that would, if you're concerned about it, then get screened, or just wait until you have symptoms. But everybody, I think the advice for arthritis prevention is kind of the same everywhere: is keep your weight down, stay limber, do some exercises. Don't torture yourself. I wouldn't say distance running is bad, but low impact exercises are better. Swimming, cycling, those kind of things. If you're concerned, obviously we don't want to end marathoning in the Olympics and things like that, because some people can go forever. Some of our research is also directed at nutrition for keeping joints healthy and keeping the articular surface healthy. And there is a suggestion that that dietary boron, which is in fruits and nuts and dried fruits and nuts, that areas of the world that have more natural boron in their diet have a lower frequency of degenerative arthritis, that the cartilage surface becomes tougher. And so but you have to lay that down when you're a child. So it may be too late for the adolescent. But there may be some dietary things we can do during early infancy that would help make stronger joints.
That's really cool, especially for my sister. She's just had a baby Otis. Hi Otis. She obviously had hip dysplasia herself, and he's had his hips checked, and there's no sign of hip dysplasia. But again, having those little extra tips and knowledge to know that just by adding in some dietary supplements as a younger child, you might be able to make them less likely to have that
Yeah, a healthy
developmental.
diet, a healthy diet, adequate sleep, exercise, lose weight, the things that everybody knows they're supposed to do. Yeah.
Absolutely. Brilliant. Well, thank you so much for that. I've got another question that comes in about childhood dysplasia. So this comes in from a lady called Sarah. And she says, should children who've had an open reduction and femoral osteotomy avoid bouncy castles and trampolines? If so, how long for?
I would hope not. I think the objective of the treatment is to get the kids to be as free as possible, and not even tell them they had hip dysplasia, and turn them loose. There's a tendency to be protective as a parent, because you sure don't want your kids to go through it again, much less the first time. But I think your doctor, in that instance, I would ask the doctor. Some doctors have different opinions, but generally once a year has passed with anything, that you're not going to change the outcome by restricting kids from things. And I'd let them do gymnastics or whatever they want to do that they're capable of: horseback riding, bouncy gyms, all those things. Um, and a child particularly, they should be able to resume full activities if things have gone well.
I think that's really reassuring because this lady in particular said that she's had so many different opinions coming in, and it's almost this what we call analysis paralysis. You've got so much information coming in from all these different angles that you just don't know what to do with it, or who to listen to when you've got all these differing opinions. So I'm sure that's probably very reassuring to hear um, for this particular lady. Um,
We have a saying, if it's physical, it's therapy. So, not physical therapy, but if it's physical, it's therapy. So uh, kids need to run and play and do those things.
yeah, absolutely.
They
We
may have trouble, but I wouldn't blame it on that. Yeah.
okay. She has a follow-up question that goes alongside with this as well and says, could I also ask, following both surgeries, would you also still expect a discrepancy in leg length when the child has a growth spurt? I feel that this has happened to my daughter in the last month. She had her operation last November, had a cast off in January, and she says, thank you very much.
That is definitely an issue and it should be followed. Generally, the leg length difference is most noticeable in the first few years. And the growing child has a marvelous gift in that they can generally equalize those things. They can, with further growth, they usually, they may get a growth spurt of the operated leg. So the operated leg can be longer or it can be shorter after surgery because the surgery itself can stimulate circulation on that side and make a growth spurt, or it can shorten the leg because of putting it back in position to make it short. But children can equalize their legs as they grow. And obviously we don't know how that happens, but it should be followed. And generally in a few years, it'll become apparent whether that's a problem or not. But shoe lifts and those things are not necessary to equalize things. Just let the kids run. There's a lot of studies that show that even a leg length difference of 2 inches in a child does not cause back problems or anything. And you can adjust that as they get to be 10 or 12 years old.
So
So,
I guess it's, again, that's something that's probably quite reassuring for people to hear, because you think of a leg length discrepancy, you want to do what you can to fix it and accommodate. And, there's so much talk about posture and the press and social media and stuff these days that you're trying to rectify these things. But from what you're saying, it sounds like the body is a lot more intelligent than we give it credit for, and is very, very good at trying to work out a way for us to function effectively, go around the things that are troublesome, try and rectify it itself. So it sounds like there's not one rule for when a bone is operated on, whether it's always going to be longer because it stimulated that growth or whether it's not. It very much depends on the individual, and the body will accommodate and do what it needs to do by the sounds of things.
right. And a lot of us have a leg length difference and don't know it. So a little bit of leg length difference is okay, but it should be followed after surgery because the hip dysplasia surgery can contribute to leg length difference.
Mm-hmm.
Now, the concern is, should you wear a lift? And we as doctors, we tend to take the patient, we stand them on both legs and we take an x-ray, and the x-ray shows this difference rather dramatically. But when you think about it, you don't spend much time standing like that as a human being. We sit a lot, we sleep a lot. When we walk, one leg's on the ground, one leg's in the air. And even when you stand, 80% of your time is what we say is spent in single leg stance. And right-handed people put more weight on their left leg than the right one. So for right-handed people, the left leg is usually a little bit longer than the right leg because it's had more stimulation during growth. And a good shoe salesman will try on your left shoe if you're right-handed, because your left foot tends to be a little bigger than the right foot. And so we have differences in our body. Your face is not symmetrical. And so running with a leg length difference is not an issue. If you think about it, when you walk along the street, if there's a curb and you have one foot in the street and one foot on the curb, you pump up and down. You don't topple over one side or the other. Your pelvis stays level. You kind of pump up and down. So when the leg length difference is great, it takes more energy to walk because you're squatting and pumping and squatting and pumping, but it doesn't cause any problem with the back or hips. So a leg length difference only looks like a problem for the hips when you stand straight on both legs and take an x-ray.
This just feels like a bit of a mic drop moment for me. Like, Wow. Like your dominant side, your opposite leg is generally longer.
Yeah.
I had
And
no idea.
we don't think leg length differences cause hip problems.
That's really, really,
Hip
really no.
hip
And
problems,
I'm desperate to do some more research and reading
yeah,
on this afterwards.
hip problems cause leg length differences, and leg length differences can cause weakness around the hip from surgery and things like that. But generally, it's not as big a problem as people seem to think it is.
That's amazing. So don't automatically jump to going and getting the orthotics and the shoe raises and bits and pieces. Have a chat with your consultant about it first before going to do
Yes,
all those
right.
things. Brilliant. Okay, so we're starting to move into a little bit more of the adult hip dysplasia questions now. So moving away from the childhood issues more into adult. There's a question that comes in saying, I'd like to know if there's been any studies done regarding the problems with for hip dysplasia that we seem to have with our hip flexors post total hip replacement. She says it feels like a hip dysplasia specific problem that no one really talks about as a possible side effect after surgery.
That's a very true and accurate observation. Um, People that have had total hip replacement for hip dysplasia have more complications. It's definitely more difficult to do a proper total hip replacement for someone with hip dysplasia than someone with arthritis from trauma or from some other cause. So my first advice was ask your doctor if he's done a number of hip replacements for hip dysplasia. And the more severe the hip dysplasia, the more experienced that physician needs to be. For the milder forms, it's not too big an issue. But we are finding, and there's a lot of interest in the what I call the adult literature about hip flexor weakness after total hip replacement. And it's kind of a hot topic right now because the improvement, it's clear that all function improves after hip replacement, that function improves, the strength improves, the ability to do things improves, even hip flexor strength improves. But after a period of time, that's the thing that you notice the most, that my hip flexors still aren't quite right. And whether that's the surgical approach or the type of implant or the way the implant's put in or positioned is things that people are looking at. The only thing we can say right now is to go to physical therapy, or I forget what you call it in Great Britain, but go to therapy. All right. And try to find a therapist who can help you do some strengthening, but it may be something you have to live with until we figure out what the cause is after total hip. It's not too common, but it's certainly common enough that people are noticing.
So it's not always to do with the approach for surgery. It's not that in order to get in for a total hip replacement, it has to be, always pulled significantly out of the way, or there's not always, there's not always a cut through or a change of location. There's not something like that that's fairly consistent that we can put it down to.
Right. It does seem to be more problematic in hip dysplasia patients, and it may be that their hip was not in the right place for a long time and that muscle doesn't work as well, or we're just not sure. But it's a real observation, and tell her to we feel for her. We're trying to figure it out. Okay.
So there's another question. So this definitely goes out of my order, but I definitely feel like it's relevant to bring it up. So this one comes in from another lady called Sarah that says, if you have a hip replacement with dysplasia and femoral deformities, should a surgeon attempt to correct the deformities to within a normal hip? I say that with normal because what is normal? But within normal parameters, and what impact would that have on then retraining the muscles and your gait patterning afterwards? Or is it better to have a custom joint that's going to allow the muscles and the biomechanics to stay the same and have that custom joint done? So which approach would you say is better?
Wow. She should be designing research studies for total hip surgeons because
She's a fellow physiotherapist.
okay, well, she's right on target, and no one knows the answers to those, and it's controversial right now. There is a debate. I don't do total hip replacements, but I know I follow the literature and go to the meetings, and there is a considerable debate about whether it should be made anatomic or positioned where it is, and it's going to take a while before that gets sorted out. The beauty of today's electronic media is that there are registries, um, we started our registry in 2009, when it seems like, 11 years ago, but the internet and communication and spreadsheets and the ability to enter data and share data in huge volumes has increased enormously in the last 11 years. So ours was kind of a groundbreaking multinational research study that collected data from electronic medical records from around the world, but there weren't any at the time to speak of. Um, Certainly not in hip dysplasia, but now the registries are coming out of other countries are going to allow a lot of detailed analysis of this. And so I hope that we'll have an answer in the next few years, but there's no answer for these questions right now that I'm aware of.
But it's amazing that all these different questions are coming out, and that they are in the backgrounds of the minds of the people that are doing the research right now, that it's being worked towards. So
Yeah.
I've loved all the questions that have come in. They've just been absolutely fantastic.
Yeah, almost every month there's a new paper that shows how total hip replacement and hip dysplasia could be improved. Or again, the classification of one of the classifications goes A, B, and C, and now they have a CA and CB, and you do this in the CBs and this in the CAs, and that's going to improve results.
Absolutely. So this next question that comes in is something that I get asked all the time, and seems like a really massive issue, and it's about nerve damage post surgery. I've had so many people asking about this to ask your opinion on. How often do people get nerve damage afterwards? Is it normal? What can I do to prevent getting nerve damage? Is there anything that can be done to prevent getting nerve damage? So I wondered if you could talk a little bit about those as a side effect of the surgeries.
Again, these are right on target and the things that doctors are trying to solve. And when all of the PAO literature has been looked at, the frequency of nerve damage is about 2%, which is 1 in 50. That's huge. I mean, if you imagine there are 33,000 airplane flights in the United States, and if 1 in 50 of them had a problem, you wouldn't get on a plane. Mm-hmm. But the majority of them do tend to resolve with time. And there have been some recent publications that show different surgical approaches and techniques that can reduce the nerve damage. So when you say it's 2%, that includes the experience from 10 years ago to now. And the incidence of nerve damage now is considerably less than it was 10 years ago. So I wouldn't be afraid to have a PAO because of nerve damage. The people that have it, I would say, be patient. Nerves recover very, very slowly. They recover at the rate of 1 inch a year, 1 inch a month. Sorry. So if it's 1 inch a month, so if you've got a nerve damage and it's got to go 12 inches to reinnervate that muscle, it's going to take a year for the nerve to recover and reinnervate that muscle. So nerve damage can recover for a couple of years after surgery.
So when we say that it's an inch a month, and we're thinking about the area, for example, that we might have that nerve damage. So say it was a left PAO and we have nerve damage down to our thigh, down towards the knee, for example, whether that's a loss of sensation or muscle activation or whatever that might be, or we're having pain into that area as a referred nerve pain. Where do we think about that 1 inch a month starting from? Is that starting from, a spinal level, or from where that nerve branches? Where does that start from?
Yeah, it probably starts from the pelvis around the hip socket. And then, but the muscle innervation would be about mid-thigh. Mm-hmm. So the muscle that it's got to get to is about mid-thigh. And it's the nerve is stunned for a month. It doesn't start for a month, and then it takes a month. So mainly just be patient. And there are some medications that can help if there's numbness and tingling and burning sensations and things like that. There are some medicines that help. The B vitamins are used for people with neurologic damage from chemotherapy and other things. Diabetes can cause tingling and nerve things, and whether the B vitamins help or not. One thing I would say about B vitamins, if you're going to try it, use the sublingual form, because a lot of it's not as digested as well in the gut as it should be, or have your B vitamin levels checked, and that might help. It's a stretch, but take the ones that dissolve into your tongue or the gummies if you're going to try B vitamins.
Okay, that's really useful to know because I had quite a few people asking about the vitamin B12 to be taking as a supplement and whether that was something that had been researched, whether there was any kind of backing to it as a supplement to take alongside of your healing. So that's good to know to try the under the tongue or the dissolvable ones rather than the harder tablets, at least if you're going to give that a go.
There are no good studies that show that it helps or that it doesn't help, but
Okay.
it doesn't hurt either.
We know that, yeah, if it's not going to hurt, then it might help some people and not others. But there's so many different things outside of the medical world talking about all of these other sort of more holistic approaches that can be taken, and not every holistic or conservative approach is going to work for every person. But if we know that there are lots of options to choose from that are safe to try, if we know that they're not all going to work for everybody, at least there are things that we can go through and we can give it a try and see if it's going to help and see which particular things out of our toolbox can work for us.
Sure.
It's a nice approach in addition to the medical side of the treatment that you're receiving. So that's wonderful.
Good point.
Um, so what can I do to prevent needing a PAO on my other side? So with this question that's come in, I'm not sure whether the person already has hip dysplasia on the other side or whether they have it on one side and they're trying to prevent perhaps it being diagnosed or something on the other side. But there's a fair conversation to have around people that do have bilateral hip dysplasia and having had one PAO done and not wanting to have the other one done. Um, and also about comparing your sides. I think there's a lot of comparisons with side to side, and no two hips are the same. And I tell people all the time that you can't always compare one to the other because the anatomy and the process and everything about that time in your life is completely different. But what's your opinion on that?
Well, I think your advice is right on target, Laura, that it's obvious that you want to compare one side to the other, but they're really not comparable. They're never comparable in terms of severity or surgery or any of the things. I suppose if you saw two that were identical, it would be pretty remarkable. So they have different degrees of cartilage involvement or ligament tears. We're right and left-handed. We use our legs and arms differently. So there are a lot of differences that don't really lend themselves to comparison. The as far as prevention is concerned, unfortunately, hip dysplasia is a structural problem. Um, you know, the socket is not deep enough to support the femoral head, and there's no way to grow a deeper socket or to make that structure change. If your teeth are crooked, they're going to stay crooked unless you have them straightened out. Um, so that's kind of where the state of the art is. And it's a debated question whether you have the surgery preventively or wait until you have some early symptoms. And almost every doctor would say, wait until you have some early symptoms because, you know, surprisingly, there are people that go a long, long time with mild dysplasia that don't hurt. And so the longer you can postpone the need for surgery without damaging yourself, it's good. So I would say that each doctor, each person is different, and you have to follow the advice of an experienced physician to guide you as to when to have surgery on the other side, because you don't want to wait too late. Um, it's better to have your own hip if you're young than to have a total hip. But if you're a little bit, let's say past middle age, then the total hips are marvelous. So the main difference is, your own hip will last longer and serve you better and has feeling. The bones have feeling, the ligaments have feeling and everything. And the total hip replacement, although you're not aware of it, there's no neurofeedback from the artificial pieces. I play tennis with people, and they get back to tennis completely after a total hip. Mm-hmm. But they're not aware that they don't have quite the position sense that they did ahead of time. There's just something of feedback from your own joints and bones that you're getting deep in your brain when you have your own joint than when you have an artificial substance in there. So you'd like to have your own if you're young enough, but the total hips are probably, they're just such an amazing miracle. In my career, they weren't done a lot when I've started as a medical student, but they're just been amazing.
So I was having a discussion with my physio friend this morning about, what is the cutoff point between getting to a point where you can't sleep or work or walk, to push yourself as far as you can with your own hip. What is the point that that becomes then detrimental? Because at some point, if you push it so far into that painful experience, you're going to lose your strength. You're going to, be stuck in this chronic pain loops. It's then very difficult to get out of. There's so many things that you're going to lose in terms of your gait training, and your support systems, that then make that rehab post replacement then so much harder as well. So is there a is there a guideline that you would perhaps give people, or is it just so subjective that you can't put an answer on that?
Well, you've posed the question in a way that I've never thought about before, but now that you've made me think about it, uh, I would say that if you're going to have hip preservation surgery, that you should do it early. As soon as you become a little bit symptomatic, that's a signal it's going to get worse. So um, as soon as you can have it done after you've noticed that it's causing any trouble at all, if you're going to preserve the hip, you should do it early. In contrast, with total hip replacement, you should wait as long as you can, uh, because you're going to replace everything. So you put up with that as long as you want if you're going to have a total hip. But if you're going to have hip preservation and a PAO, then get in there and get it over with and do it and enjoy your life. So it's either early or late, nothing in between.
That's cool though. That definitely helps with the conversation that we were having this morning. Um, so the next one is something that I think a lot of people have wondered for quite some time. Have there been any alternate treatments studied for hip dysplasia besides the PAO and the total hip replacement? When would you predict that we might have an alternate, less invasive treatment option?
That's going to be a while. I think the only alternative treatment option would be to strengthen the joint surface or repair the joint surface, because the gliding surface of your joint, the cartilage, is what protects your joint. And there's certainly work being done with stem cells and biology and the chemical composition of articular cartilage that could strengthen the articular cartilage and make it last longer, do cartilage transplants, things like that. But even injections and those kind of things, at the moment, there isn't anything on even the near horizon that's going to do that. There's no alternative or complementary treatment. Most of the medications and over the counter things, avocado oil and things like that, that help decrease inflammation and decrease pain, they don't decrease the degeneration process. So you can get help with pain and with inflammation, but if you've got hip dysplasia, it's a mechanical issue and it's going to get worse, as far as we know, until we can find a way to strengthen the cartilage surface itself.
So I think definitely about 5 years ago, there was some stuff in the press about the stem cells and the cartilage, sort of injections and stuff for the knee. And I think that's been sort of in the back of the media for a little while about those developments in the knee. But I didn't know whether there was anything kind of on the horizon for the hip. But it's good to know that that's not sort of something that's coming up in the next few years to hold on to.
Unless there's a breakthrough that we're not aware of, it's going to be a while before it helps for the hips.
Okay. So this next one has a little bit of a backstory to it. So there's a bit of context for this next question. So I hope that's okay to read this through. So this next one says, my left PAO was over 2 years ago. During surgery, my nerves probably got pinched. I couldn't move my leg for weeks at all and properly for a few months. The feeling and most of my abilities are back now, but I have a hard time trying to run again because I need nearly double the amount of strength for my operated leg to pull it up. When the weather changes, every step hurts. Because of this one damaged nerve, I realize I can pull my leg further with massive willpower, but it's extremely exhausting and it hurts. I notice that it's getting better. It's excruciatingly slow, but my non-operated leg gets worse and worse. I'm waiting for the list for my second PAO. My questions are, will I ever be free from pain and able to run without being exhausted very quickly after 1 minute? And if my nerves got damaged the first time, is it more likely that they will be damaged again in the second PAO?
Well, the answer to the last question is no, there's not an increased risk the second time around. And as I've said, the techniques and things have improved. So if she's seeing an experienced PAO surgeon, he's probably using a slightly different technique to protect those nerves. And there are ways to monitor them during surgery that have been developed too. But that not everybody's using them, but it's possible. As far as the solution to the right one, there's so many issues there that it would be hard to make a reasonable comment. But that can all be investigated with EMG studies and a trip to a neurologist. And someone should be able to get a handle on that and see exactly where her problem is and whether the muscle's starting to regenerate, whether the nerve's starting to come back. There are ways you can test for that and to answer some of those questions. But I couldn't answer that without, seeing a fair extensive battery of tests and things. So
Of course. So the advice there is to make sure that you're getting that muscle testing, that nerve testing done, so that you can see what your potential is for whether that's activating, whether it's not, whether you can get more activation with strength and conditioning type work, or whether there's anything else that needs to be done. So push for some further investigation to understand that a little bit more about your specific.
yeah, and sometimes go to a different doctor. Good doctors don't mind if you get another opinion, if it's a good opinion, so.
How common do you think that is for people to go and see multiple surgeons and get different opinions, and whether they will all work together to find a common ground, or is it more common that people don't appreciate it? What's the kind of feeling in the consultant world about that?
Well, I guess my feeling is that the opinions are more consistent than people might realize. If I see a patient and then they go somewhere else, where they're going to have new questions when they go to that doctor, and he's going to answer some questions that I didn't answer because they thought of new ones.
Yeah.
And so when I would give a second opinion, I would always point that out, that you're going to get more information out of me than you did out of the other doctor, because you've come to me and you already know what he told you. So anything I tell you is going to be new. And I would say, look at the big picture, that there are general similarities, that some doctor may recommend surgery and another may recommend surgery with a slightly different incision or a different approach, but they're both recommending surgery. If you go to experienced physicians, I think they're going to be aligned more often than not. There is a tendency to think the doctors don't know what they're talking about, but because they disagree, but they do tend to agree in a big way. So I would say keep that in mind and not go with the opinion that they're not going to agree. Try to find out what the agreement is. But on the other hand, I will say that a lot of this is very subjective, and there isn't a clear path. It's not like fixing your auto where the alternator's broken and your battery's dead and you need a new alternator, and that's the problem. There are differences of opinion, and I think it doesn't hurt to get additional opinions. And in confusing situations, you just have to pick the doctor that you think has the most experience and that you trust the most and go with that one.
So I just wrote down a question that I kind of answered there. So what classes as an experienced surgeon in hip dysplasia? Because you can go to your local hip surgeon, your local hip consultant, and they might be a very experienced hip surgeon. But what would you say counts or classes as an experienced hip dysplasia surgeon or consultant?
Well, I hesitate to throw a number out there, but a lot of times those numbers are known, and generally it is related to volume. Surgery is technical, so a surgeon that's doing, maybe at least one a month of PAO surgery and has a background experience, to me that would be kind of a minimum number. There are certainly surgeons who can do more with less, but I would want to go to somebody that's doing a fairly high volume of PAO surgery,
Hmm.
um, or whatever it is, and then you can ask them how many do you do, and if they you can tell whether they've given an evasive answer or an honest answer. Uh,
So
and,
this came up on a recent podcast episode of mine, and we were talking about questioning your consultant and how difficult it is sometimes to question that person who, you know, has all these qualifications, and you know that their time is precious, and you're sitting there going, well, how many have you done? And you're like, do I have the confidence to question that person? And of course, we, you know, we have every right to ask those questions and have that information. But I guess that my question is, you know, as a doctor in this profession, do you guys mind us questioning you about these kind of things, so that it can give maybe a little bit more confidence to people to say, okay, I'm gonna ask my consultant that next time I go in.
well, a lot of it is, of course, how the question's answered and asked and say, have you ever done this before? Or, how often do you do this procedure? Is one way to go. How often do you do this procedure? Is this a common part of your practice? I think there are some things to do. You can look around the waiting room and see if people are there for their headache or for their hip. Um, and I think most physicians that are comfortable with themselves aren't put off by those questions. They actually would like to say, "Oh yeah, man, I do more than anybody in the Southeastern United States. You can check it out." Um, so I think that information should be more public, and I'm sorry that it's not. That they should publish volumes and things like that. It's available in cardiac surgery. You can find out. Cardiac surgery volumes and outcomes and percentages of mortality and all kinds of stuff. But you can't find that out for hip surgery. But mainly ask around. I think the usual things is ask around, but there are ways to ask your doctor and get a feel for his experience and comfort level with what he's doing.
Hmm. Okay, thank you. Um, so this next one, that comes in is more of a subjective feelings, for after a total hip replacement, and this person is asking whether there's any research regarding how people feel subjectively after a PAO, or a total hip replacement, whether there's any difference between a hip replacement for a normal hip, like with general, you know, osteoarthritis, as opposed to a hip dysplasia replacement. So subjectively, how people feel afterwards.
I'm not aware of any direct comparisons of feeling afterwards, but I would I would think that the subjective feeling after a total hip would be the same, um, depending on severity. I mean, if you've had a very severe, completely dislocated hip that's been out for all your life, then that is not going to feel the same, and it's going to have a lot higher complication rate. The muscles are going to be different than others. So if you're feeling different after a total hip replacement from your hip dysplasia, then you probably are. Um, but but I think a lot of that can be overcome with therapy and counseling and coaching and things like that. Um, as far as I don't know if that answered the question. Did that answer the question?
I think it's a very difficult question to answer, because I think even if you had a group of 10,000 people in a room that had had a total hip replacement, for, you know, whether they were dysplastic or not previously, the only thing questions that people are going to be able to answer is how they felt before and after, and is that really comparable to anybody, whether they've had dysplastic or non-dysplastic hips. So I think it's a very difficult question to answer. And it's like the comparisons that I get when I ask people, you know, what's your pain level out of 10, for a bit of a subjective question. They go, well, I don't know, but how does that, you know, mine could be completely different. And I say, well, we're only comparing to what you feel in these different, you know, we're not comparing that to other people. And that's, I suppose, a similar kind of approach. You know, you're asking how you feel afterwards, but does it matter, or does it have any difference to you what other people feel before and after? So
Right.
it's a it's an interesting question, that's very difficult to answer, I think. But definitely interesting to have it discussed. And I hope
Yeah.
the person that's asked that question
Well,
feels a little bit better about not perhaps comparing to other people, perhaps.
yeah, one interesting study that's just been started at Hospital for Obstetric Surgery in New York is asking the patients ahead of time, what are your objectives and what do you expect to get out of this? And the preliminary studies show that when they say, I want to be this and this and this and pain free and walk better and all that, and then they ask them 2 years later, did we meet your objectives? What they're finding is that they're like, well, I still have some hip flexor weakness and I can't run and I can't play tennis. I can't get to the net as quick as I could. But all of their objectives that they stated before surgery were met. You know, they're free of pain. They can walk, they can go out with friends, they can dance, they can do all these things. So we have a tendency as humans to want to be better, which is good. And I wouldn't say that's always the case, but the improvement after PAO surgery and after total hip surgery is usually so great that after a period of time it becomes normal, and then you notice other things. So I think we have to keep in perspective where we started uh, to some extent.
Absolutely. And this next question is something that's definitely related to that, but I feel from again another discussion with another physio friend of mine is that when you go in for your follow-ups post surgery, there's a feeling within the community that when you're going in for your 6-month checkup, you're the consultants perhaps expecting it to be your discharge appointment from surgery, and then you go into your sort of yearly follow-ups and things for maintenance and checkups afterwards. But there feels to be a pressure to be where you're going to be and to have reached the limits of what you're going to reach achievement wise at this 6 months. So is that something that is felt by consultants, that you'll have got the majority of your recovery by that 6 months, or is it just something that you're just checking in to see where they are, and what's the kind of feel behind that?
Well, you're hoping that they're meeting all the milestones and doing as well as they could. But of course, you are looking for things, for little things on the X-ray, that maybe the bone didn't heal quite right, or the screws are working loose, or things that the patient may not feel. So it's worth keeping that appointment. And they have shown that patients can over or underestimate their results, because they may not be honest with their doctor about problems there, because they don't want to disappoint the doctor. So that happens too. And so I think the key on both sides is to be as honest as possible with what you're feeling, what you're going through, and for the doctor to do the same thing. There are some studies that show that hip dysplasia patients probably do struggle a little more than other people, both before and after surgery, because it's it's had an impact on their life. Either first of all, they tend to be younger, and it's had a bigger impact. It has implications for their children, for their sisters, for other family members. It's not just their hip. It's a whole range of things that they've been dealing with, uh, that does make it does add a little bit element of stress, both to the before and the after surgery. So there's a difference in between hip dysplasia patients and other patients in regard to their emotional status and things like that. So another reason to separate hip dysplasia surgery and results from other types of procedures, and we're seeing more and more of that. We're not being lumped. I don't have hip dysplasia, but I say we because I feel like I'm part of the community. Is we're not being lumped in with all the other hip conditions as often as in the past, and that's going to be huge.
There's another recurring theme that comes up within the podcasts that I do, and it's that hip dysplasia feels sometimes more like a mental battle and a mental challenge to cope with than a physical one. Sometimes the physical thing, that muscles can regenerate and repair and get stronger, and your bones will heal, and so physically that side of things feels like it's manageable. But because hip dysplasia isn't known by so many, this is something that we were talking
Right.
about at the beginning of this conversation, and it's happening to people that are younger than are perhaps traditionally seen as needing hip surgeries. a lot of people do feel alone. They're struggling with their mental health. They're being socially, you know, feeling like they're socially excluded. Whether that's the case or whether it's not, it's that feeling of being isolated. So the mental health issue is, I think, fairly massive, and I think that's fair. I can say that with a fair amount of confidence from the amount of people that I speak to. That yeah, the mental health side is tough. Do you find that from speaking to people that you've found that this is a big area within hip dysplasia to tackle?
Yeah, that's so true. And I think part of it too is that there has been a lot of increased awareness about hip dysplasia and a lot of specifically hip dysplasia directed study with the advent of the PAO and the awareness of the problems of total hip replacement and hip dysplasia and other things. And it takes a while for that to be trained. And you may go to a doctor who says, that he may not really have the latest on how to diagnose hip dysplasia from x-rays. Well, if he was trained even 15 years ago, that might not have been a core part of orthopedic education. The orthopedic residents coming out now can all look at an x-ray and say, this is dysplasia, this is not. But prior to that time, there weren't measurements of center edge angles and acetabular inclination and all these subtle findings of hip dysplasia and labral tears and MRIs and arthroscopy. We've got things now that I would say an older surgeon may not have learned, or it may not be part of his thing. Now, the younger surgeons may not either, but you could go to a doctor and he says, I don't know what's wrong with your hip. And then you find out, we found that the average delay in diagnosis of hip dysplasia is something like 18 months and you go to 3 different providers before it gets diagnosed. And that's just because it's the diagnosis and understanding of adult hip dysplasia is really a modern phenomenon. So that also throws people off when they go to the doctor and they say, he didn't know what it was. Well, it wasn't in his area of expertise, so.
So, I mean, there was a question that was, I think, the last one on the list for today, and it says why dysplasia and PO is often misunderstood and not known about in the medical community. And you just answered that beautifully. I suppose that people, the technology is so different now, the resources to diagnose are so different now, and like you said, if it's not your field of expertise, then you may not have had the opportunity to have that training. The medical profession is so vast and there are so many areas that people can specialize in, and if you think every person that trains to be a doctor has the choice of so many hundreds, if not maybe thousands of areas that they could potentially go in as a specialism. So to then specialize in specific hip dysplasia conditions, the amount of people out there that are going to be that focused to be reading all of the latest literature, be doing all of the latest practices, techniques, going to group study with other consultants that are doing that. You think how many people are actually doing that?
Yeah,
And
really.
no wonder people don't necessarily know about it.
Right.
And it's very
And
similar.
it's actually a very subtle condition. I mean, the x-ray interpretation of hip dysplasia can be very, very subtle. And so you can look at an x-ray and say, gee, that hip looks like it's in the socket. It looks fine. Uh, it's easy to be fooled.
And I found that it's very similar within the physiotherapy world as well. There are a few physios in the UK that are very hip dysplasia specific. I can think of 3 off of the top of my head, but I did an online course with this guy called the Hip Physio, and he's absolutely amazing. That's his tagline on Instagram. And he did this course, and there were 25 physios on there that were all interested in the hip and wanting to know more about it. And everyone was raising their hands as to who had heard or treated or had any kind of experience in hip dysplasia. And I was the only one. And I was like, but all of these are experienced physiotherapists, but to again have such a narrow area of specialty is so rare that all of those individual physios would have had their area of expertise that they were all specializing in.
Right.
What I love about, I wanted to bring this back to your website, is that on the International Hip Dysplasia Institute, you do have lists of practitioners that are available in different areas that you can go to your website, somebody who has made it a trusted area. You know all of the people that are on that list. Their qualifications have been checked. It's a trusted area that you can go and know that that person has experience um, through your website.
Well, thank you. I would also emphasize that there are a lot of good doctors who are not on our website, because we have tried to recognize those who have contributed beyond the practice of taking care of patients. So as they've done research, they've done advocacy, they've educated, they've really advanced the field of hip dysplasia, and not just giving good clinical care. And I can assure you that there are a lot of good, excellent practicing orthopedic surgeons who know a lot about hip dysplasia that don't publish and don't do research, and they spend all their time being educated. And I would go to one of those in a heartbeat. So we're trying to we can't recognize all the good doctors that can do this. And fortunately, the number is growing in leaps and bounds, and the amount of knowledge that's being taught at scientific meetings at the national level, international level. Hip dysplasia is now a very hot topic. So I think we're going to see more and more awareness and more physicians in the community who can easily diagnose hip dysplasia and think of it. It's a matter of thinking of it. And the difference that's been made in 10 years is just huge. And I go back to the Whitneys, and I don't know whether we were just part of this development that was occurring, because I think we were, but I also think their donation and getting IHDI out there and getting collaborators together and doing all this has helped spur a lot of interest in being more aware. And people can do this. Ask your doctor. If you know somebody that has a hip problem and they're going to a doctor and the doctor can't figure it out, then tell them, did you ask your doctor about hip dysplasia? And sometimes it's just a matter of suggesting that as a possibility.
It's a two-way street, isn't it? As a patient going in, if you have the awareness that there is a differential diagnosis and a possibility of it being hip dysplasia, and you can then put that idea into the mind of the doctor,
Yeah.
then that is just as effective as that doctor knowing about that as a differential diagnosis and giving you that information. So the more people that hear about it, that know that it's an option for a diagnosis, the more we can get
Right.
that diagnosis a little bit sooner. So
Exactly.
the awareness is not just to spread within the medical professions. It's the more that we can get this out to the people of
Absolutely.
the world, that the quicker we can get these diagnoses made.
Yeah.
So
Well said. Yeah.
so I know that I'm taking up perhaps a little bit more of your time than we had planned, but I wanted to know if there's anything else that you wanted to add or discuss for us today, before we start wrapping things up.
No, I think we've covered a lot of ground, but I'm just so optimistic about the future of hip dysplasia. And the other thing I would say is that this is a curable and preventable problem. It's a mechanical problem. It doesn't require pills. If we're going to eliminate this, it's something it shouldn't require pills. It shouldn't require surgery. It shouldn't require any of that stuff. It just, as you said, it needs early diagnosis and good preventive management. And I think this is something that we should make a huge impact globally. And the burden of disease of hip dysplasia globally is enormous. We haven't even talked about third world countries and places where dislocations are common. And we got a call from Afghanistan. They've got 200 babies that are walking age with hip dysplasia. They can't even operate them all. They can't find any of them in the birth area. They just got 200 kids that were asking for a surgeon to come help them do this. There are places that are doing 5 and 10 and 15 operations a week on babies with hip dysplasia. So we have an occasional missed diagnosis in our society, but this is a global problem. Every culture has hip dysplasia. So keep up the good work.
This is something that I know that Keisha is doing a bit of work with, as well.
Yes.
As global networking, the global availability of
Yes.
resources, treatments, and awareness, that trying to raise and spread this to a worldwide population, because like you said, the the United States, the United Kingdom, Canada, a lot of those countries have, like you said, a slightly earlier diagnosis rate, treatment rate, access to treatment rate. But the work that's being done with the Hip Hope and International Registry to start making progress, and make this a worldwide equally accessible treatment progress is something that's just so wonderful. And if anybody wants to know a little bit more information about that, please go and follow the Hip Hope Network on social media. They have a wonderful event coming up this Sunday.
Sunday, yeah.
This Sunday,
May 30th.
that is recognising some wonderful hip legends, including Dr. Sebastian. You've also been referred to me over the last week as the Beyonce of the hip world.
I don't sing though. I wish I could sing.
So yeah, it's if you are interested in learning a little bit more about it, and learning how you can raise awareness and just know a little bit more about the hip dysplasia world, then please go and have a look on their Instagram, sign up for the event on Sunday, and learn a little bit more about how you can help in this community. So I'll close this out now, but I really truly appreciate your time.
Thank you, Laura.
For just being such an amazing interactive part of this community. It takes, you know, a lot of time out of your diary to have these conversations, but I know that so many people will appreciate the time that you've taken and the questions that have been answered. So thank you so much.
Thank you. It's been a pleasure. Thank you, Laura.
You're very welcome.
Bye-bye.